We have over 84 clients globally, and it allows us not only to evaluate products from all over the world, but we also are working in educational programs to the tune of over 450 live programs last year. So the premise of today's course is really about upping our game in diagnostics. So the premise, deep down, is for the past 100 years, I feel all we've been doing is guessing regarding diagnostics, guessing. So let's go back to the 1920s. Now, I want to make sure I'm getting an unstable internet. Hang on a second. This is, hang on. This is the world of webinars. Takes care of that. And we should be good. Okay. Hang on. Let's go back. Here we go. So circa 1920s, what was diagnostically driven dentistry? I mean, obviously, we're not talking pandemic, even though this was post swine flu pandemic as it be. Well, really, what was diagnostic dentistry? It was an explorer. I doubt they were even using perio probes. And they would be basically using sporadic x-rays, sporadic. Let's go up to the 1950s. Again, dentistry really hadn't changed much. Explorers, maybe an occasional perio probe, and x-rays. Even on the left screen, you can see the dental assistant smoking a cigarette while she's talking, while the doctor is addressing the patient. So let's go from the 20s to the 50s to today. You can see in the background a traditional FMX. And again, where are we with diagnostically driven decision making? So the goal of my program is really to talk about really what's the juxt of this. So sensitivity is the ability of a test to correctly identify a disease. So if you test for COVID and you know someone is positive, if you know it, and you test and you get 100% sensitivity, that's sensitivity. If you get a false negative, that means it's less sensitive. That's what we're dealing with today. Specificity is the ability to correctly identify those without the disease. So again, a true negative rate. So if you take an antibody test and you know somebody has not had the disease, and you get a false positive where they show you something that's not supposed to, that would be a false positive. Okay, so take an x-ray. If you know there's no decay, okay, and yet there is decay, that's a false, that's a problem. So we go from sensitivity to specificity. So let me just basically go this way. An explorer really is not the most diagnostic approach for fissure and smooth surface caries. We're going to get to cone beam, don't worry. Now, when I tell you that, an explorer, a brand new explorer, is at best 50% sensitive. In other words, if you know there's a cavity, 50% of the time you will get a false reading. So let's just take this. Here's a blown up image of a patient of mine 10 years ago, a molar. No decay noted on the x-ray, negative to an explorer, negative at this time using Logicon, yet at that time I was using Diagnodent with fluorescence and it had a 65 reading. Now, when you look at that and you could see a little brown halo, would I trust the explorer or the x-ray or the Diagnodent and the fact that I could see a brown halo? And again, showing you the lack of accuracy of an explorer. So as I went in with a fissurotomy burr, I'd already gotten the patient numb. This is me already drilling access just to show you. So I have just started my entry point. There was negative to the Explorer, negative on the X-ray, and that's the hole. Now, sadly, this patient had been going to a dentist in New Jersey who was her uncle for years. He was in his mid-70s and just used Explorers and X-rays. Both are very low in my world of sensitivity. 2D X-rays. 2D X-rays are not the most diagnostic approach for initial proximal caries. They are not. The false negatives that we get are astounding. So I'll give you an example. So if you look at this patient in 2000 and 2014 and 15, and you look at tooth number 20, in 2014, you may get a hint of some decay. 2015, it looks arrested. 2015, we used CaryView. That's when we started launching CaryView into our practice. You can see the decay right there on the lower right. It is well into the DEJ. There's no guessing. So routinely, our protocol is interproximal decay, X-rays, not great. So we'll use, for example, CaryView or transillumination as our protocol for evaluating interproximal decay on patients anywhere from 14 to 30, always primary. Why take a bite wing X-ray as our routine diagnostic versus CaryView? So on the left, you can see no decay. On the right, after we did the restoration, you can see how deep it was. So this is what happens. We want to be more sensitive, and we want to understand if there is decay, we want to be drilling, at least if it's well into the dentin, we absolutely want to. What's beautiful about CaryView is you can actually track early enamel breakdown, even deeper enamel breakdown, and see if it progresses. And if it's not, you can warrant doing nothing or warrant using Icon interproximally to literally infiltrate and seal that area. And again, that's just part of an overall diagnostic course. So these are changing times in dentistry, and it relates to creating far more efficient diagnostics that result in better decision-making for both observation, if that's what is needed, for prevention, or if necessary, treatment. And the way I look at this, and I don't treat children, I can't stand them. I mean, I love my children, I'd love your children, I just don't want them in my chair. And when you read this from the Academy of Pediatric Dentistry, it talks about contemporary management of dental caries. And it identifies, you have to identify an individual's risk of caries progression. Are they high risk, low risk, or medium risk? And understanding it per individual. And can we now use active surveillance to assess disease progression? You cannot do that with an Explorer or very routinely a 2D X-ray. Current diagnostics just don't allow you to monitor that. And I'm going to show you how we can monitor not caries, but lesions with cone beams. In dentistry, this also relates to creating far more efficient diagnostics that result in better decision-making for both you, the GP, and really allowing the specialist to deliver a higher quality of care. This can ultimately lower the cost to the patient by creating the best treatment plan with the highest chance of success. So again, you want to have the most information. If you have the most information, now at least you can make a logical treatment plan or treatment plans that are best for the patient. You got to listen to the patient and utilize the customized diagnostic approach to involve and communicate with that patient. That's what we're going to walk through today. Because the bottom line of modern diagnostics is I want to lower the cost. How's that done? I want to lower the failure rate. I want to lower the failure rate. Imagine if you did a crown on a tooth and it had a periapical lesion, but you couldn't see it 2D, but you could see it 3D. And yet you did the crown, you couldn't see anything 2D, But a year later, they come in and they're swollen, and now you have an abscess. What if you could have seen that before doing the crown? That's a cost failure to the patient. The other thing about the modern day diagnostics, if you have it all in one office, you can be far more efficient than sending it to a periodontist or an endodontist or an oral surgeon. If it's all in one office, now you can also provide the quality of care because you're making the ultimate best in decision making and working best with your teams. I look at diagnostics really should be customized to what your office's focus is. It should be specific. What are you going to be using on that patient to diagnose them? So for example, on a 17-year-old in my practice, a new patient, I don't take bite wings. I take a low dose cone beam, 10 by 8. I'll look at the thirds, and I will use Carey View, and I will use Spectra for fluorescence. I don't take bite wings on that individual. And it's all to the betterment of our patient because they're all better as far as diagnostic capabilities. So let's go into modern diagnostics. Digital x-rays are one, of course. Number two in my world is fluorescence. It started with diagnonin, and there are other systems out there. I use Spectra from Air Techniques, and that's for caries detection, both occlusally and on smooth surfaces. Transillumination has been huge in my practice for interproximal decay. I can also use it to evaluate cracks, craze lines. It's just a great documentation tool. We also use digital records, and as iTero expands and expands, they are using time-lapse, and time-lapse is a great digital tool. And I see iTero way ahead of the marketplace in that regard. In cone beams, they've just expanded our vision from 2D to 3D. To me, it's about creating the want and the need via diagnostics. It's about providing information and with providing diagnostic information and creating a path of communication to involve the patient. I'm going to walk you through this. This will guide them into wanting their treatment. If they want their treatment because they know they need it, you're going to have far greater treatment plan acceptance. And all exams must have that same philosophical approach in your office. Whether it's my initial exam or a recare exam, which I'm going to start with, you have to have the same philosophical approach. So in our office, recall exams are not the old days with a hygienist taking an Explorer and picking away into fissures and getting false readings. It's totally changed. So this is my wheel. This is what goes on in an hour. And in that hour, the hygienist is really only cleaning or doing their debridement for 20 to 25 minutes in a normal prophy or a 4910. This is not the wheel for active therapy, such as scaling and planing, or scaling and planing and curettage, or full mouth debridements. Now, this is for 4910s and prophies. And so what happens in this hour, most of the time is spent on clinical screenings by my hygienists and then sharing the findings. Right there. More time than basically routine hygiene. And so what happens is my hygienists all have to wear loops and lights. They all have to be laser certified. We get them laser certified. And whether it's oral cancer screening is one of our 3 steps in oral cancer prevention and evaluation every time. Whether we're using Spectra, whether we're using 2D x-rays, whether we're using an intraoral camera, or we're using Carey View, all of these things come into clinical exams, all of them. And this doesn't even include saliva exams and other things like that. But again, these are our routine diagnostic tools. So first point is more than half of all our CBCT imaging is done during a hygiene appointment. That's crazy, more than half. So what happens is this. If we're following an area on a patient, so let's say number 5 had a root canal done, and I'll show you this, and basically we're following the treatment on number 5, and we want to see if the lesion healed, we'll take a 5x5 scan a year later, not a periapical. And we'll charge only a portion of a fee for that 5x5 scan as a post-op. All too often in the next case, you'll see I need more information than a periapical. and we no longer take FMXs. We just don't. John Julian, who you'll hear speak, he turned me on to this concept maybe 3 years ago. And kudos to John Julian, by the way, a great speaker, great implantologist as a general dentist. And I haven't taken an FMX in 3 years. There's no reason to, because what happens is you take an FMX and then you have all these question marks and then you end up taking a cone beam. Well, why take the FMX? So a normal hygiene appointment based on risk assessment every 1 or 2 years in a 50-year-old would be potential every 1 or 2 years vertical bite wings, and every 5 to 10 years a 10x8 or a 15x13 standard resolution cone beam. We don't take FMXs. So let's just walk you through this. So here's a patient in hygiene. She comes in, she's been a patient of mine for 20 years. She's 72, and she tells my hygienist, I was swollen over the summer. I took an antibiotic and the swelling went away. And she said, I had pain in that upper area, but once the swelling went away after I took my antibiotic, I have no pain. My hygienist sees nothing. She does a percussion test on all 3 teeth. She's so well trained. She takes a periapical and they're really all negative. You can see a little something maybe on 13. There's a little slight bite change maybe on 13. She has me adjusted. Everything's ready when I walk in the room. Would you know which tooth to do a root canal on? She was swollen. You could guess it's 13. I don't like to guess. So what would I have done in the past? In the past, I would tell the patient, let's follow it and see if it manifests so I don't have to guess. I never guess anymore. Well, I try not to. So what happens? We take a CBCT. And if you can't see the periapical lesion now you have a problem. So now I have this lesion here. Boom. I know what I've got to do. I know I have to do endo. So what I'll do is, and again, this is pixelated. What I'll do then is I'll go look at the tooth itself and go, is it 1 canal going all the way down? I'll do that. Is it 2 canals going into 1 canal? I'll do that. Is it 2 canals separate? I'll do that. Is it 1 canal splitting into 2 or 3 canals? Referral. If it's really curvy and I can't follow it, referral. So this allows me guidance because I don't want to waste my time doing endo where I don't think I'm going to do a great job. I don't want to struggle. That saves me a tremendous amount of stress. So this not only tells me I've got an abscess, I can use this to guide, am I going to treat or not treat? So what you have to understand is, in general, radiographs 2D underestimate bone loss because a substantial amount of the buccal lingual plate needs to be demineralized in order to see something. So that's a problem with 2D. There's an inability to differentiate between the defects in the buccal lingual plate. So this is where 3D just shines unbelievably. So with that, as our recall exam, now what I can tell you is I'd like to walk you through my initial examination. This is on every patient. Now, I've been in practice now 35 years. I am into cone beam now 6 years. PreXion's my second cone beam. I won't go into my first. It just broke down too much, needed to be recalibrated. The support was terrible. It just wasn't good. My experience with PreXion was 6 of the catapult evaluators evaluated it, and all 6 swapped out the machines. We sold our first ones and bought PreXions. The support, mine hasn't been down a day. The support has been unbelievable. The training's unbelievable. Now, mind you, I'll teach cone beam anywhere, but my allegiance is to the company that best supports their customer. The true purpose of an initial exam, and you'll see what I'm talking about, should be to really understand what the patient wants. What does the patient want? Then I want to educate them and inform them. And this is really done wonderfully through advanced diagnostics. And I'll walk you through my call. So the phone rings and we do an initial screening. I'm happy to send you any forms anybody wants. My team goes through this, and I need to know about previous cone beams, previous x-rays, previous medical history, everything. But I'm highlighting 2 things. Tell me about this is my one administrator does all of our new patient intakes. Tell me about your chief concerns. And if you had a magic wand, what would you want done? These are the magic questions, because I want to know, what does the patient want done? I don't want to walk in there and just tell them, this is what you need. I want to start with, what do they want? And this is my morning. I get to the office, not now, I wish I could. We're only doing emergencies, but my normal day, I get to the office around 5:30, 5:45, and I start at 7. And basically, I'm prepping my day. So when I look at new patient intake forms, as you can see 2 of them, my team knows everything has to be in the office the day before. So when I get to the office on the day I'm seeing a patient, new patients, all the forms are done. Everything has to be here. The x-rays, CBCTs, anything. And I'm also sending thank you notes. I write personal thank you notes. And I'm telling you, this really, really works. And when I send a personal thank you note, routinely, I'm crediting any referral $25 for them to, in other words, if somebody refers somebody, they get a $25 credit. That's what I offer. And then we offer $75 to any new patient as part of their new restorative treatment plan, if they need restorative treatment. Would I pay $100 for a new patient? All day long. All day long. Because I know through analytics, the average patient in my practice spends $1,411. If I know that and I want to keep them for decades, I'm just going to tell you, what's $100? It's nothing. So I monitor my SEO, my internet. We monitor everything to make sure we're getting ROI. As we go into the initial exam, I'm very much into the medical part of it. And as you learn more and more about the medical part, this helps guide you with decision making, especially in my world where I'm treating most of my patients are over 50 and 60. They're over that. And I could have a day with just 90-year-olds. And I really want to get to know that patient. So I always look at past dental history. Have they had braces? This becomes huge for me. Last year, we found 46 new patients. So almost 10% of our patients, new patients last year, 46 had external or internal resorption. And what's amazing is resorption, routinely external resorption, is caused by some trauma to the periodontal ligament. That's what routinely causes external resorption. And what's amazing is the #1 cause is ortho. So as you get a cone beam and you're looking at a history of ortho, and it could have been 40 years ago, you want to be looking for resorption. And in this case, this patient wanted, as she ever had her teeth bleached, she wanted to have her teeth bleached. So these are just questions we ask. I want to know their wants. So from that, we'll take pictures like you've all heard, but pictures lead to discussions, no doubt about it. But we also do, and I'll walk you through it, we do digital imaging on every case so we can do time lapse and check for recession. So iTero with time lapse, if we bring a patient in every year, so in the recall appointment 1 year later with iTero, we can evaluate time lapse. Is there more recession? Is there more tooth wear? Is there tooth movement? I can look at all these things and through the data, show a patient if there are any changes. But by digital imaging, for in this case, the patient wanted to bleach their teeth. Now I've already captured where they are. It's a great learning tool for the patient. Now, if they want to bleach their teeth, all I have to do is click and send, and off goes a digital image to Ultradent, which they now do. They'll make me my trays, and whether the patient wants night or day treatment or whatever bleaching company you want. But again, I've already digitally scanned them as part of my initial exam, which I'll get to. So if they want to bleach their teeth, fine, all that information has already been had. So here's the flow. In the first 10 or 15 minutes, I go over the patient's main concerns and their wants. I go over their medical and dental history. And I can do a precursor evaluation of their occlusion, their joints. I can look at oral pathology. And at that point, I'm not looking for cavities, by the way. I'm not probing gums yet. I'm just doing occlusion, TMJ, and oral pathology. But I've looked at their mouth. And routinely, I'll order a 10x8 cone beam. Now you think about this. A 10x8 cone beam, as you'll see, takes 7.7 seconds once the patient is aligned. 7.7 seconds with no discomfort versus doing a full mouth series of x-rays with those sensors. Are you kidding me? I hate those sensors. So it's a much more pleasurable experience, much more pleasurable. Now, routinely I use a standard dose, which I'll get into, but if it's a kid who's 17 or 18, like my kids, I do a low dose. I'll walk you through that too. If the patient has joint issues, and I'm going to work with my buddy Tony tomorrow on the case in my practice, and we're going to look at joints, I take a larger scan of 15 by 13. So let's talk radiation. Most people think radiation is higher with a cone beam than it is with, let's just say, an FMX. Let me walk you through this. Radiation is measured in microsieverts. So if you take a set of bite wings, it ranges between a perfect cone beam series of 4 would be 5 microsieverts, but many systems are not capable of that, and they can go up to 32 microsieverts. And FMX ranges from 34 to 150, routinely over 100. The digital Panorex is 8 microsieverts, routinely is 20 to 30 microsieverts. And if you get on a plane, which none of us do anymore, and we fly from LA to New York, your body gets 40 microsieverts of radiation. So how does that relate? Okay, I'm just gonna go, is a full mouth series really necessary today? And it's really not. Here's what I look at. This is basically PreXion's dose level chart. I'll show you this one, and I'll show you one from CAVO-CUR. If you look at the chart, a standard in red, a standard image that is 10 by 8 is 78 microsieverts, which falls in right in the same amount of radiation as a full mouth series of x-rays. If you do a rapid scan, it's 25 microsieverts. So versus taking a digital Panorex of 20 microsieverts on a teenager, you can get a rapid scan, great details, see their impacted wisdom teeth, see if there are any supernumerary teeth, and look at the exposure time. The exposure time below the blue is 2.3 seconds. So that thing is whipping around their head in 2.3 seconds, and in a standard, it's 7.7 seconds. I've never done an ultra high D. I have no idea why you do that for 23 seconds. It's like, I think, putting your head in a Susie, like a little Susie bagel, Susie oven, or whatever those things used to be called. But I just want to show you the radiation is so in comparison with a digital pan or an FMX. This is CAVO-CUR, standard resolution, 78 microsieverts in their 9 by 11 system. So again, these systems all have so much more value because there's so much more information, and routinely with the same or less radiation of a full mouth series of x-rays. For those of you who are scanning, you don't need to see this. For those of you who aren't, routinely in my practice, what replaces an FMX, if you're not looking at the joint, in my PreXion world is a 10 by 8. If I'm doing TMJ, I routinely use the 15 by 13 image. If I'm doing a post-op a year later of one tooth, then I'll do a 5 by 5. Most endodontists only use a 5 by 5. They don't want to see anything beyond where they're working. But a 10 by 8 is routinely what I take. So what happens is the cone beam's up, and I'm reading the cone beam while my assistant is digitally scanning the patient and taking vertical bite wings, period. Takes me about 4 to 5 minutes to read a cone beam. And if I see pathology or something I'm not comfortable with, I will send it out to a cone beam reading company, because for that, I need the reassurance. But if I don't see anything, routinely, I just don't send it out. I just don't. I feel I'm very comfortable reading these cone beams. But if I see pathology, and you will see pathology and you need help, you'll send it out to a service. They charge $85. I charge the patient $85. So this is kind of the process in my office. I'll walk in, the cone beam's been read, there's the digital scan, and then you'll see some vertical bite wings. And it might be a PA or two of the anterior teeth. That's it. That's routinely what I walk into, and now it's about 30 minutes past the hour, and now I have all of this surrounding me. This, to me, is how I do an initial exam. Digital scanning today, I love it because it allows the patient to be involved. So routinely, the assistants are responsible for reviewing the scan. My assistants scan the patient. I'll do it when I'm doing crown and bridge and implants, but they're responsible for this. So if they miss an area, they'll go back in and clean up the area, just like if they miss a bite wing x-ray. So the initial exam with this patient, she spoke, I'll say, fair English, and the dentist downtown Chicago had told her she needed a couple teeth extracted, I think on the maxilla, and needed 28 crowns, basically. It's pretty much, that was the consult, basically. So he forwards me the x-rays, and I love when patients come from downtown Chicago because their fees are usually 25% more than mine because I'm on the southern side of Chicago, near the University of Chicago. So this is what she's surrounded with. Let's walk through the experience. So here's her FMX, and you can see there's obviously an upper right molar that's got to go because it's only root tips. An upper left molar that's got to go, only root tips. She's got a loose lower left bridge. And he basically said, we're just going to do full mouth, crown, and bridge. So let me just show you some close-ups. So there's a short fill on number 30. Maybe some pathology around 29. I think you're guessing, you don't know. And now you start to look at number, I don't know, an upper bicuspid with a root canal. Is that pathology? There's no periolus. So do you treat it? Do you follow it? What do? You see these all the time. Number 10 had lost a filling. The gutta-percha was exposed. Does she need to have that root canal retreated? There's no symptoms. The bridge is loose. Patient wants to know her options. Yeah, there's plenty of length. Is there enough width for an implant? You can't tell on a 2D x-ray. So we take our PreXion image, and routinely my assistants do all this. They're great. And you can look at airways and all that other stuff, which is wonderful, and even in a 10x8. And as you start to line up everything, you start to go through your evaluation of, in that 4 or 5 minutes, while the patient's getting digitally scanned and having bite wings, I'm lining up my segments and evaluating. And already in the lower right, I can see there's pathology. That concerns me. I can go look at it here in the sagittal view. This concerns me. I can see some, we'll say, periapical radiolucencies on the upper teeth. I can't say they concern me, but again, this gives me so much more information than a 2D image. Let's go look at it a little closer. Here's 29 and 30 pixelated, so you can't go by the images, but here's 29 and 30. Nothing was on the x-ray, 2D. You got a circumferential defect around 29. 30's got some distal rarefication. This is the sagittal view. Sagittal view, obviously, I've got a problem with 29. Hang on a second. Let me see why that's not. Oh, hang on 1 second. I've obviously got a problem with 29. And is the problem 30? I need more information. Now with 29, I may have a J lesion, which often may be representative of a fracture, a vertical fracture. So now when I want my endodontist to come on and look at this, I know what I'm looking at. Now I'll let my endodontist come on and look at this. Is this tooth worth saving? You can see the wraparound defect coronally. Look at the 2D image. I'm not placing any blame on the dentist downtown Chicago, but think of the cost of failure. This is how I started my course off with. If he would have done 28 crowns on this patient or whatever number, and now you've got a short fill and you've got periapical pathology, you can't see it, and 29's got this issue, and he didn't see it. This is all going to be costly failure. And believe me, this has happened in my practice. This has happened in my career because I was using 2D imaging, and I was just guessing. Same thing here. So here's a periolus, not perioluses, these are periapical radiolucencies on the upper teeth. If they're asymptomatic and the fills look good, if the fills look good, I may just leave them as they are. That's what I would do. Number 10 concerned me a little bit more because she was missing a restoration and I was worried about coronal microleakage. I'll rescan her. I just told her because she had many other issues. Could we do an implant? That takes you 5 minutes to treatment plan in an office. And with a digital scan, you can get a stent made and it makes the guesswork so much. So there is no guesswork. So here's her experience. She's sitting in the chair with all this data. Now the cone beam is sitting in front of her. The iTero is sitting on her left. My assistant will walk her through and look at the patient. They're intent on this information. I don't want to just talk to somebody. I don't want to just show them. I want to involve them. It's involvement that becomes the key to treatment plan acceptance. And with treatment plan acceptance, look what's happening. They'll start touching the screen. They'll touch the iTero. They'll start to understand what their problems are. And let me go back. I'm not giving her a treatment plan that day. She's going to have to come back. It'll be on me. We'll have a consultation where I'll walk her through everything. Why? I may want the endodontist to come online and I can do an endo consult. I've already full mouth probed her, so I can tell the endodontist exactly the clinical condition. I'm going to save the patient either going to an endodontist, paying for that consultation. I can get that all done. Same with my periodontist. So treatment plan acceptance. This is what's amazing in the United States. 78% of patients after their treatment plan do nothing the first year, 78%. So only 22% start treatment. That's terrible. What percent of new patients book follow-up visits nationally? 41%. That means 59% of the time you're taking in these new patients and your bucket's just leaking. So 59% of the time patients are not coming back. Here's what's even more crazy. Nationally, the top offices retain 65%. That's the top offices. The worst offices retain only 18% who come back. The average is 41%. If you looked at how many of your patients never came back, it's numbing. So the key is you want them to come back. Because if you're spending money and you're trying to, let's put it this way, if you're spending the money to market your practice, and that's what I do, I will market my practice. I only see 4 or 5 new patients a month. The rest go to my associates. It's all about keeping your patients. So this is Weave. And Weave is a fantastic system. We moved over from our previous software. We're a Dentrix office. I can't stand Dentrix. We're moving away from that. But this integrates into, obviously, as a software system or as a management software. It will just go into your management software system. But here's what happens. I do morning huddles every day, and I look at what happened with our new patients or our treatment plans from the previous day. So in this case, I pull up Weave. It's on my app in my office. We had 3 new patients. 1 patient never scheduled. When you look at it and you click on new patients, I'm going to yesterday. So if you look at new patients, it will show you yesterday, 7 days, and 30 days. So what do I want to do? I want to follow up the next day. So what you'll see, there's a red bar. The red bar says this patient did not make an appointment. You click on their name, and as you click on their name, what comes up is you can call them, text them, or email them. And so now all I want my front team member to do in the morning huddle is we're going to either text or email them. We don't call. And what routinely we'll do is we'll send out a personal message. So in this case, it's good afternoon, Mrs. Faulkner. Dr. Graham wanted me to follow up. It'll only take an hour. This is what he's recommending. We have found 20% of the time the next day they'll book the appointment. They didn't make the appointment, but 20% of the time they'll make it as soon as they get this text or email, and we prefer texting. We just want to make it personal. So imagine If these patients aren't coming back and you can up that 20%, I mean, that pays for weave in itself. This is restorative treatment plans. There were 8 patients diagnosed, only 3 accepted treatment plans that day. I'm not happy in the morning huddle looking at that. So I can now look on weave and see those red marks. I can click on every one of those patients, and then you'll see what was diagnosed. And now we're just going to send an email or a text to follow up. Again, if you're not following this stuff, you're really missing. So here I've invested in Cone Beam. I've invested in all this stuff. Now I've got to do the analytics to close the deal. Routinely, I can just tell you, once you start evaluating this, your team members that are not closing cases or treatment plans, you're going to see that, and it's humbling. I can only tell you it's humbling. So here's patient involvement. This is what I want. I want my patients to be involved. Quick selfie. And here's the coup de grace. I run a tight team. I have like 2 offices, and this is like my little private 4-man office. This is Sarah, I'll call her my office front team member, but she's like my do-it-all on my side. She's now going over the in-office dental plan, which is going to be huge after COVID. I don't see PPO patients. You're not going to want to see. I just think you're going to have to minimize them in your practice. It's going to take longer to work. It's going to take more time. You're going to have PPE fees. I just think just have your own in-office dental plan. Over 1/3 of all of our patients are on our plan. So she's going over this plan with a new patient. Patient's pulling out her credit card. I haven't even gone over the treatment plan. That's her next visit, but I know this patient's going to come back. She's not going to go ask for another opinion because she's going to sign up for our plan. So this is kind of our plan. We did it ourselves. We didn't do it with anybody. We've got 3 more plans we're coming out with post-COVID. We're going to be doing this all with Clear. Clear just can monitor everything far better than we can. But you come up with your own plan, whether in Clear or anybody else. This isn't insurance, but it's fully transparent. I go right after PPOs. And as you can see, I offer CareView and Spectra. Velscope is all part of our system. So the same diagnostic tools I talked about earlier, they're included in our dental plan. That's how we customize it. So I just want to show you one quick second case. This is Kobita. She's 77 years old, type 2 diabetic. She came in with faint pain in the upper right area, and she had a perilous. She had pain on her lower left to chewing, and she asked us if we could tighten the tooth. She went to a dentist last year, had an FMX done, and the dentist did the cleaning. The dentist recommended her redoing an upper bridge, and she felt she was being sold. And so her sister referred her to the practice. Here's the FMX that was forwarded. It was a very good FMX. Okay, so she's got faint pain and a perilous on the upper right. There's a root tip on the upper right. You can see periapical pathology. Do you have enough information to diagnose what you're going to do? I don't think so. No pain on the upper left, none. Some tartar. What do you see? Well, I can tell you what you see on the canine. There's resorption right in the middle. There's resorption. You don't know whether it's buccal or lingual, internal or external, but you can, there it is. And I don't think anybody caught it, but there it is on the x-ray. But you're still guessing, where is it? You can't see it. We couldn't see it. That's the clinical view. You couldn't see the resorption at all. Her lower left, yeah, I'd say she's got a problem and why it's loose. You can see the bone loss. I think the 2D image is pretty sufficient there. We've got a big problem. Let's do cone beam. So we take a cone beam, again, great image from PreXion. Can't speak enough. Routinely, I'll use the RACEM, go to about an 8 or 10 filter, and I'll just walk through the entire process. I'll take a look at the upper area number 3 first. And that's what I'm looking at. Line everything up, and we'll just go through this. So again, this is all pixelated because I've blown this up. So here's she has that upper right bridge. You can see the retained root tip, but you can also see in this axial view 3 gutta percha points. Well, the MB2 was totally missed. So here's what's amazing about PreXion. As I scroll deeper, or coronally, which is just deeper, I can see the amount of bone loss in the furcation, but you can actually see both buccally and lingually on the first root, on the mesial root, MB1 was short filled and MB2 is right there. So you can actually see MB1 not filled all the way to the end, and MB2 was never filled, never. So as I go through this, and this is me like showing it on an Apple phone, where I'm just scrolling up and down number 3, just capturing a quick video. This is on my Apple phone. I can see so much more just scrolling up and down. Again, scrolling up and down with my Apple phone again here. This is the coronal view. The literature states you have better success rates when retreating previously substandard treatments. Well, this was substandard. Short fill on MB1, and MB2 was never found. But on the other hand, you have a worse prognosis when the lesion is as big as this. So I just told my endodontist, I just sent her a copy and said, take a look at this. Just sent it to her. My patient doesn't have to go see her. And she said it's a guarded retreat, but the patient, if he wants to try it, let's try it. If in a year the perilous and the lesion isn't healed, well, if the perilous isn't there if it's still there in 3 or 4 months, we're gonna have to do something. But if the lesion hasn't really healed, we could always go in and do apical surgery. Here's the upper left where we saw the resorption. Well, now you know it's on the lingual. It's not involving the nerve yet. Let's take a different view. Here's the coronal view. It tells you I'm above the palatal bone, I'm subgingival, and so if I lay a flap, I know I'm not going to have to remove bone. I love knowing all this. The endodontist said, you don't have to do endo on 11 at all. Just lay a flap and treat it. We basically restored it with a glass ionomer, an RMGI. Digital scanning. So here's her digital scan. I'm just overlaying the x-ray. The software doesn't do that. Now I can explain to the patient, it's an abutment. What do you want to do? I can do an occlusogram. I can show her a variety of things. This is where we need to put an implant because you only have first bicuspid occlusion. I can show her the tooth that has external resorption. I can show her the tooth that has the apical pathology. If we take off the bridge and put implants in, I can show her where that will be. I can show her on the digital scan, this is where we would drop an implant with me just treatment planning it during her second visit. This is her lower. This is what we're gonna have to take out. Do you want to replace that with an implant? When she comes back for her second visit, I've already got everything ready for her. We have plenty of bone. I've already spaced them accordingly the right way, and we can do 2 implants however she wants to go. I have enough room, and here's the coronal view, here's the sagittal view. I sent this to the periodontist, and he goes, we absolutely can do implants in 4 and 5. What do we want to do with 3, 13, and 20? And then he says, of course, can you make me a stent? Of course I'll make him a stent. I've got the cone beam, and I've got the digital scan. It's the easiest thing in the world to make him a stent. Her lower arch. So now, all I want to do is use today's technology to evaluate, diagnose, and ultimately bring the patient back to go through their options, costs, and timeframes. Let's go back to this image. You're guessing. What are you going to do with tooth number 3? What are you going to do? What are you going to do with that resorption? You're just guessing. This is why I don't take FMXs anymore. How many pathologies are we all missing with 2D imaging? I missed it for 27 years. This is just a typical experience of a new patient. Routinely, they come back for a second complimentary visit where I can review everything and give them different treatment plans, offer my in-office dental plan, or offer financing. It's about listening and communicating with the patient. I create the workflow. I believe the GP creates the workflow with the specialists, not the other way around. And she was so happy. She felt she got great options. And now I see her husband, I see her daughter, but I won't see her children because I hate kids. Ultimately, she wanted to save her bridge. She knew it was guarded. She didn't want a partial. So we've already done implants on 13 and 20. She wanted to treat number 11 as soon as possible. And we started her perio. This is 1 year later. Here's her post-op scan. You can see how much the bone is filled in this axial image. In the coronal image, you can see how much the bone is filled in. We've had great success. She's thrilled. Sagittal view. This is our treatment of number 11, no periapical changes. We laid a flap, put an RMGI in, and she's been asymptomatic. She had some cold sensitivity for 2 weeks. That totally went away after 2 weeks. I offer all of you to join me on the new norm. It's how we're dealing with COVID. It's a daily thing I launch. It's you can find that at 2 locations. One is at www.midwayedu.com, or you can go to Catapult Education and see it there also. We have thousands of people following us, contributing. We had a town hall meeting today with 500 people joining us on our open discussions. I know we're in challenging times. I want to thank you for your time tonight. I just recommend be safe and be smart. If you haven't seen my recommendations on screening, you can find them on Catapult Education or at Midway. You need to reach me personally. You can reach out to me at lou@catapulteducation.com. I'll take some questions now from Tim and group, and I just want to thank you for your time. Have a great, great evening, everybody.
Dr. Graham, thank you so much. We did have a bunch of people ask about, well, a lot of people said, great webinar. How can we watch it again? It is being recorded. So if you put your correct email on the registration, I will be sending the video out to everyone. So that'll be coming probably in the next hour or so. Now, if anyone has any questions regarding this lecture, you can write it down in the comment section or unmute yourself and just ask Dr. Graham. There is one right here, Dr. Graham. Could you please provide a copy of the forms and protocols for your recall exam and new patient exams?
I'll be happy to. Here's what I do is, if I can do one of 2 things, Tim, what I'll do is I will send them to you and you can send them to everybody. How's that?
That works for me.
That way you stay in contact, and I'll send you my in-office dental plan. I'll send you my new patient intake form, and I'll send you our medical and dental history forms. You got it. That's all ready. It'll go out to you tonight.
Fantastic. It says, do you have any advice for learning diagnostic using CBCT?
So I'm going to just tell you this.
Hang on a sec, Dr. Graham. This is from Dr. Tapia, and she just received a new PreXion. So congratulations to that doctor.
So, congratulations, you bought a great system. I mean, there are great systems out there. I just happen to love the team at PreXion. I would say as far as initial training goes, your reps will train you unbelievably well. PreXion also offers some great training through maxillofacial radiologists. I teach for them. John Julian teaches for them. Jeff Horowitz teaches sleep for them. So I would just say stay tuned with PreXion. They focus on great educational programs throughout the year, and we'll get you definitely up and running ASAP. We're a really tight-knit community, and we love to share. So I think training first starts with the rep, and they have some great online trainers like Tony who train me. So they have trainers, they have reps, and then they have courses from a lot of doctors who are their speakers and radiologists who also obviously know how to teach this system. Yeah, that's what I would recommend. Next.
So no more questions right now. However, if you guys are interested in more information on cone beam PreXion units, I'm going to send out an email with the video with Dr. Graham's forms. Just reply back to me that you guys would like to do a remote demo. We can show you our software, get into a little more details. And after that, you guys are interested in learning more or purchasing, then we will get you in touch with one of the dealers that actually sell PreXion.
But
So any
I would
more questions? Go ahead.
I would say this, Tim. I feel the reps really represent the company. The dealers are fine, but it's really the reps who walk the walk. And I mean, we've had my rep, Krista, in our office 6 or 7 times. And this is really important, everybody. You know what? You get a new employee and they've got to be trained. There's a new software update. We've got to be trained. There's never a fee. There's never a charge. And and openly, here's what I would tell you. If you're a new user, you should send your first 20 scans to PreXion. Let them evaluate how good your scans are, what they can do to make them better. Because when we started, we sucked at scans. And so what happens is now we can do this remotely. So they can come on remotely and evaluate you and tell you this is what your team needs to improve on. It's all of, they got a great image. It's all about positioning. And it's an easy system, but call PreXion, call them out, let them review some of your scans, and you won't be calling them afterwards because you kind of learn how to nail these after a while. Okay, next.
Dr. Cordero asks, which software do you recommend?
So I'll be honest with you, Tim. I only use yours. My first one was obviously very fancy. I know yours will be continuing to get improved, but I use your system. We do all of our implant work on your system, and we just work with the lab, and they make our stents for us. As far as other software goes, I don't know, because I pretty much just use yours to evaluate what's going on in their mouth. So I just think right now that's the software comes with the system, and that's what we use, if that's the question.
I believe it is. Dr. Graham, we got a doctor wants one in Brazil. I don't think we're selling in Brazil right now, but I'm going to find out. I'd like to branch out into Brazil. I think once the lift is for the airlines and we can start traveling, I will be the first to see this doctor.
And Tim, I'm happy to go with you to train him in Brazil.
So, but I'll be reaching out to him.
Okay.
I just have a lot of people saying, great job. Thank you so much. As always, Dr. Graham, I appreciate you being there for PreXion and the doctors.
You got it, bro. Take care, everybody. Stay safe.
Thank you guys for joining us.
Thank you.